Our next session is now our panel. As I said earlier, we've been compiling questions that have been coming through our online webinar, and we've now compiled the panel. We've got Dr. Chris Moy back as our panel chair. He is going to be joined in person here by Adam Monkhouse, the Assistant Director of End of Life Care, who spoke earlier. As I mentioned, Sam Cox, who's just given us a beautiful story of her mum, is online to join the panel. I'd like to introduce you now to Dr. Melanie Turner as well, the presiding member of the Voluntary Assisted Dying Review Board. And straight after the panel discussion, we're going to hear from Melanie. Claire Fellingham is still with us online, who'll be joining us. Jocelyn Small is still online, who'll be joining us. In person here, we've got Dr. Roger Hunt back on the panel, and Lauren Cortis, lead pharmacist, also for Voluntary Assisted Dying Pharmacy Service. So I'm hoping I've got everybody online. I'm just looking at the logistics here of all of this, and people are nodding at me and they're giving me the thumbs up. So I think I've got you all. I'm about to transfer my microphone over to Dr. Chris Moore, who will act as our panel chair. We have allocated about 60 minutes to actually conduct a Q&A and answer as many of the questions that have been coming through online. So I'll hand the microphone over.
Thank you so much, Pam. So thank you to all the panelists, and we hope to get through as many questions as we can. We've had some fantastic questions, so thank you to all of you that have contributed. Obviously, we won't be able to get through everything, but we have tried to summarise some of them into the questions that I'll be putting to our panelists today. So look, I think it's absolutely apt that the first question should go to Roger. Now, Roger, as a palliative care specialist, I have had this in a meeting where essentially somebody said, after I gave a presentation about it, they said, look, VAD, we'll just leave it to the palliative care specialists. They're the only ones that they'll do everything from top to bottom. It's got nothing to do with us. You know, how would you respond to that sort of comment, in terms of the perception of VAD?
Thanks, Chris. It's not just a palliative care job. Of course, palliative care practitioners can be involved in the process. What we know from the Victorian experience, and I think the Western Australian experience as well, is that about 80% or more of people actually die in their own home. And we also know that the vast majority of practitioners who do the training are general practitioners. Now, that's quite sensible. The second group of medical practitioners are oncologists, which makes sense too, because about 75% of people who undergo VAD actually have a diagnosis of advanced cancer. So it's GPs, it's oncologists, and down the list of it, you get palliative care doctors. There are neurologists, because the second major diagnosis is neurodegenerative diseases, most notably motor neuron disease, and then some other diseases as well, but it's mainly cancer, 3/4, and motor neuron disease. So we have general practitioners as the main grouping of doctors, then oncologists, and palliative care, of course, needs to be involved in parallel to VAD for just about all the patients. Anyone with terminal illness should have access to palliative care and get palliative care, get good palliative care. But then it's up to individual practitioners as a matter of conscience, whether they're going to participate in helping the patients down the VAD pathway or not help. But if they're not helping with VAD, they can certainly help with symptom management and help the patient and families with all the issues that arise in terminal illness.
Thank you, Roger. Look, and I will just say in that meeting, I did point out also that it was never enshrined in legislation that was palliative care specialists are going to provide this. And the other thing to keep in mind is ultimately, if you think about it, this is just another therapy option that will be open to patients who have a terminal illness, which is causing them significant distress that fit the criteria. And that may apply in a whole range of specialists. And many of those specialists are going to be required to be involved in, for example, also, providing second opinions about the prognosis of a condition. So there's going to be a whole host of doctors that are going to need to be involved. Look, the second question I'll point to Dr. Melanie Turner. How will people know which medical practitioners are going to be participating in voluntaries dying? And is there going to be some public list that's going to be available out there that people can look up to find that out?
Excellent. So I think that what we're really hoping for is that people who go through their journey with a terminal illness will have a number of practitioners they form therapeutic relationships with. And most people will have these first conversations with someone that they know and someone that knows them well. Not every practitioner needs to have done the training to look after patients as far as VAD is concerned. But what we think is most likely is there'll be a number of people that will do the training, and in the path of looking after the patients that they see, it might be something they offer to their patients. We're not going to have a list or a downloadable application kind of who could I see. The idea really is that we're going to encourage good solid therapeutic relationships with practitioners, people who might be conscientious objectors or may not feel that they're keen to do the training or maybe too junior in their experience to do the training would be able to ask other doctors that they work with. They could contact the Care Navigator service and they'd be able to help patients refer on to someone who can assist them. That's really what we're hoping, because those therapeutic relationships with other doctors will still be important all the way through, whether you're doing VAD process or not for the patient.
So thank you. And I think you're reiterating the point that I hope that, there are doctors going to have conscientious objection, but I hope that the first thought is not about how they're reacting to the situation, but they're actually thinking about their patient in consideration while considering their own conscientious objection and being very cognizant of that. Adam, look, in when it comes down to thumbtacks, this is a very potentially complex pathway a journey that people have to go through. Let's talk about the practicalities of the Care Navigator service in terms of how it will relate to patients and to also other health practitioners. Are they going to be the ones you're going to call? Are they going to be the ones who are going to be, with the patient? Are they going to be like the contact person, who are going to pick up? What is their role in all this, really, in practical terms, in that journey?
Yeah, thank you, Chris. The Care Navigator service is a critical enabler. We've learned that from Victoria and Western Australia. And really, the range of services that they provide it's just that it's a range. There may be some people that just ring up and say, look, I'd actually just like some information. Can you send me a link to the website? Can you send me a fact sheet? And that goes all the way through to where the Care Navigator is effectively holding the hand of the patient, of the family, of the medical practitioners involved, and stepping everybody through the process. So every scenario, every situation is different. Every person is different. And the Care Navigators are really going to build up that capability, the knowledge of the process, the knowledge of the act, and the connections and the relationships to allow them to really facilitate and smooth out the process. From a technical point of view, absolutely the Care Navigator can be the contact person. Absolutely the Care Navigator can be there supporting the person, supporting the family, supporting the medical practitioners at any stage of the journey. But what we will see is we'll see a range of them doing that appropriately and appropriately for what the person wants and what the medical practitioner needs to assist the process to flow smoothly. Just building on Melanie's answer to that last question, in the clinical portal, there's an option for medical practitioners to tick that they would like to share their information with the Care Navigator service. And that allows the Care Navigator service to build up that relationship with practitioners to assist in some of those referrals.
And thanks very much, Adam. So look, Sam, could I pose the next question to you, please? The question I'd like to ask is, in your case, what was the time frame for your mother to actually go through the whole pathway? Was it in terms of total time?
The total time it took quite a few weeks. Obviously, accessing it was a bit tricky to begin with. And then once we were passed to the care coordinators, Mum got the information. We were able to contact Dr. Gareth he was able to come out and have a chat with us about it. And probably another, I would say 4 weeks later, once we had done the 2 doctors signing off and we had a talk with, I think it was Alex, he was also a psychologist, it was all in place. So Mum, after that point, she read everything she could on it. And to be honest, I think it was about 4 weeks. So it wasn't a rushed journey, which it shouldn't be unless there is need for. Every fact and everything was considered. Everything was disclosed from the practitioners and from the care navigators. So it was a tricky journey, but we're thankful.
Thanks very much, Sam. So I'll just flip the question over to Adam just to fill that out question from a legal point of view in South Australia. There are some limitations. Could you clarify the minimum time that it would take for an individual to actually pass through from go to woe in terms of the VAD pathway?
Of course. Thank you, Chris. So the legislation is quite specific on this. There is a minimum time frame between the first request and the final request. The final request must be made a minimum of 9 days after the first request. However, there is an exemption to this, and that is if during the prognosis assessment by both the coordinating and consulting medical practitioners, if there is a general agreement in that assessment that the person their death is imminent and they will die within that 9 days, then they are able to access the pathway sooner than the 9 days. However, at a minimum, it must be 1 day after the end of the consulting assessment. So there is the opportunity to I guess, be flexible when the case needs it. But it's also important that we make sure that coordinating medical practitioners and the family, the care navigator service, the pharmacy service, and everybody is discussing, setting expectations for how long this will take. Inclusive of, for example, in a coordinating first assessment, if the coordinating medical practitioner identifies that a number of specialist referrals are required, then that necessarily is going to take an additional time to obtain those specialist referrals. So it's about making sure that we're all talking and all acting on the same page together as a team.
And being realistic about complex situations as well. So thanks, Adam. Jocelyn, could I just pose a question to you, looking at it in an aged care facility where you work with a great number of people that are beyond just doctors? What role do other health practitioners play in voluntaries dying, such as nurses, social workers, and other allied health practitioners?
Yeah, in an aged care setting, actually possibly it might be similar in most healthcare settings. The role I would see is trifold. One is particularly the support for the resident themselves to ensure that they've got the access to the information and access to the resources that they need. Going through the VAD pathway is ensuring that the family or close contacts or next of kin also are supported and have access to information they need. And then within our setting, we need to ensure the role of the health practitioners is that we're supporting each other. It's very important that staff are supported to understand this process, have an opportunity to opt out if they want to, but also have the counselling and support through and after. So that the role I see for health practitioners, that they are key to ensuring the information and the support is there.
Thank you very, very much. Claire, could I pose the next question for you about within the health services that you work, about what do health services really need to think about in terms of the management of individuals, health providers, or particularly doctors who have conscientious objection? And has there been a shift as time has gone on, as confidence has built up in the process? I'm interested in that. So, I mean, obviously there's deep conscientious objection, but there are those who may be not so much conscious, but just scared of the process initially. Could I just pose that question to you?
Sure, that was to me, was it?
Yes, that's right.
Yes,
Thank
right. So I guess conscientious objection exists on a spectrum. So you've got sort of strong conscientious objection at one end and conscientious participation at the other end. And there, of course, are going to be people who exist at both ends of that spectrum. Most people are, as you say, sort of somewhere in the middle. They're kind of non-participators. They don't know how they feel about it. They probably just don't really want to think about it because it's quite challenging and quite new and emotional, and everyone's busy as it is. Strong conscientious objection is entirely justified and upheld in the legislation and enshrined in the law. So I made a very big point during the clinical leadership and implementation phase to make sure that people knew that all views on voluntary assisted dying would be supported and respected. However, there is a big difference between conscientious objection, that's personal objection from your own sort of moral compass, and conscientious obstruction, where you actually prevent a person from being able to access voluntary assisted dying. That is not legal. In fact, according to our Act, that is illegal. And that's why there are timeframes that exist that doctors should be aware of. And Sam, I'm really sorry to hear that that wasn't the case with your experience. But all doctors, when confronted with a first request, even if they are a conscientious objector, shouldn't impede a patient's process through the law, because it is a legally available option in the end-of-life care spectrum. So I think what's really important is to acknowledge that people have very polarizing views and that it's a very, emotional and divisive and quite controversial subject, and that everybody's views are there to be respected and we should all be professional. But also, at the end of the day, we are talking about individual human beings who are suffering, who are attempting to access something to which they are legally entitled to access. So conscientiously object to your heart's content, but don't obstruct a patient from being able to access it. That's obviously based on the individual practitioners. In terms of an institutional approach to conscientious objection, that's rather more challenging and probably too complicated really to get into. But I personally feel similarly that an institution shouldn't be able to conscientiously object to voluntary assisted dying service provision if they are also funded to provide a public service to public patients. But that's definitely above my pay grade.
Thank you. Look, I'll just point out that, practical types of impediments that we've seen before have been active referral to people that don't provide the service, on giving people the runaround. And we've seen that in other areas such as termination of pregnancy as well. And I think the thing to keep in mind is that the trick is that what we don't want is people imposing their views onto other people and getting into that really tricky area, whether they're doing that. And look, the bottom line is that there's a potential for people to run into the very tricky area of coercion the other way. We're actually trying to coerce somebody not to do something they would want. So there's some legal ramifications for them as well. Look, I'm going to go to Sam again. Sam, could I just ask about, and it was interesting, you mentioned the matter of grief. I mean, were there issues about grief after your mother died, and did you have to manage it, or I'm interested how you did that, if that was the case?
Grief is a natural part of life, and unfortunately we all experience it. Thankfully, we were supported by a lot of people around us. My kids were supported, and they knew it was okay to grieve. They knew it was okay to express emotions. I feel I was asked to help the WA VAD team with a podcast about the experience, and I felt that helped me process a bit of grief, helping share Mum's story and hopefully helping future families. And even speaking at the memorial, that has helped me heal, and I feel it's helped me in my grieving process. I still miss her every day, and I still wish I could make that phone call. But we do the best we can do. And my kids, we were so blessed to have her as long as we did. And I'm just so thankful for the VAD program.
Can I say, I think that that was a wonderful answer, as particularly the fact that grief is a normal process. But I think, isn't it a wonderful thing that you actually followed through with what your mother wanted? And isn't that the lovely thing that you did? And I think in many ways that is part of the way of actually, an acceptance of it.
Absolutely. It wasn't my choice.
So could I then just pass on to Adam? Adam, look, we're not talking now about care navigators. We're talking about the voluntary assisted dying liaison officers, which are going to be in the local health networks. Could I ask, are they going to be available in all local health networks, and what's their role going to be?
Yeah, thank you. Look, we were really lucky today to have both Emily Pumper and Joyce White to talk to us about the two services. They go hand in hand. I think that's the important thing. There are subtleties between them, but ultimately we are all one team here to assist people in being able to access voluntary assisted dying. The voluntary assisted dying liaison officers then are specific to local health networks, and in that way they help to support those local health networks in terms of access within public hospitals, but also supporting the workforce that work within those public hospitals. And we know that, obviously the South Australian public health workforce is a very large workforce. So what we've got in terms of the setup, we did the modelling, obviously on the numbers, and we tried to translate that into what that would look like from a resource point of view. So we've got one voluntary assisted dying liaison officer within each adult metropolitan local health network in Adelaide. So that's the northern, central and southern local health networks. And then one role that sits across the 6 country local health networks. But I would stress the point that they work very closely with the Care Navigator service. And effectively what we're talking about then is one team that works statewide and supports each other.
Thank you very much. Lauren, I haven't introduced you. I haven't brought you into this yet, but I've left a curly one already for you. So this is one that's, this is a practical reality and an issue about safety. So if a patient passes away naturally before they self-administer medication, does the contact person return the medication and used for it to be disposed of? And then the second question to that was, is there a safeguard to ensure that the contact person, be it family, friend, isn't at risk of using the medication in a state of grief at that point, and making sure that it comes back, instead of making sure that it comes back?
Well, I'm glad I've got that question in writing so that I can properly think about it. In terms of, that's a really serious risk that we need to think about, in terms of this is a high risk medicine that is, at a dose that is intended to cause death, and we need to take that responsibility seriously. We need to ensure that the people who are accessing voluntary assisted dying take that responsibility seriously. And I guess the key safeguard in the legislation about this is the contact person. So yes, if the person dies naturally before using the substance, it is the responsibility of the contact person to bring it back to the medication, to the pharmacy. And we're still working through the logistics of how we make that process as easy as possible for that to occur. In terms of reducing the risk around if a family or friend could use that medication in a state of grief, it's really about us educating the person who's using voluntary assisted dying that their responsibility extends beyond their life, I suppose, in that they have a responsibility to keep their family and friends safe from this medication, and to really select their contact person appropriately, and to communicate with that contact person to ensure that they're present at the time that they're using the medication, or at least aware of their plans so that they can collect that medication and return it as quickly as possible.
And I think that's a really important point, that contact person becomes a very important person to complete the circle as far as the return of the medication. But as you said, they really, I think in amongst this, there's responsibilities all around that need to be understood, including for the individual in appointing a contact person. Keep in mind, of course, that the care navigators theoretically could be at various stages the contact person as well. That's right, Adam. Yeah, thank you. Thanks so much, Lauren. I'm going to now go to Claire again. Claire, what's happened in situations where individuals have lost decision-making capacity along the way in South Australia, and I assume the same similar legislation that, you know, if somebody loses decision-making capacity along the way, they can no longer follow through with the pathway. Could I just ask what has been your experience in those situations, and what happened after that time? How did you act?
Sure. Well, yes, just to reinforce that absolutely capacity is fundamental to a person being able to journey through voluntary assisted dying. The entire process, ours is 10 steps. Every step has to be driven forward by the person. And even up until the final moment, they have to be completely in control and say, yes, this is absolutely what I want. So people losing capacity during the process is a reality. It's a challenging one. And I'll tell you the truth. I learned about it through a difficult experience at the beginning, where I was looking after a patient who lost capacity quite close to the end of the process. We hadn't really spoken at length with her extended family members about the implications of that would mean that she was no longer eligible for voluntary assisted dying. And it caused some very, very challenging family dynamics, because the family were very, very upset that we weren't going to fulfill her wish for her, and were saying, oh, but you know that's what she wanted. Can you just get on? Can we just do it now? So what we have learned from that, and certainly what I do now in every single one of my patients that I look after, right at the beginning, at the first assessment, I say to them, I go through the eligibility criteria and I say, look, sometimes nature catches up with us. Sometimes things happen, we get thrown curveballs, and it's absolutely fundamental that you retain capacity. And if you lose capacity, I'm very sorry, but that means that the process will have to stop. And I tell as many family members as possible about that. But then what I also do is offer them reassurance. What will then happen is that likely represents you moving into the terminal phase of your life, and we can support you and mitigate your suffering through excellent quality palliative care. And the vast majority of our patients are already under the umbrella of palliative care. And we really reassure people and their families that just because the voluntary assisted dying journey has stopped, it doesn't mean that we abandon them. We get our palliative care colleagues on board, and they support them in exactly the way that they've been doing for decades, providing excellent quality end-of-life care and symptom relief.
Thanks so much, Claire. That's a wonderful answer. And then that gets to the point that I made at the very start. Palliative care is still really important here. It's still going to be there through the process to mitigate symptoms, to be there afterwards if somebody loses decision-making capacity. But also, I think I've said this before at the beginning, we need people to complete the advanced care directives to make sure that they're very clear about what they want in terms of end-of-life wishes, particularly if an individual loses decision-making capacity along the way, even though they can't actually use it to actually convey that they want to proceed with voluntary dying. They can't appoint a substitution maker to follow through with it. That's really important. But what we need them is to actually write down their wishes about the end of life beyond voluntary assisted dying. And we also need people to, doctors, if they can, to complete resuscitation plan 7-step pathway, for example, to ensure that things that patients don't want to happen to them don't happen, particularly emergencies such as resuscitation. So thank you so much, Claire. Lauren, I'm going to throw another question at you, if that's okay. So, when can where and when can they administer the voluntary dying medication, and does a patient actually have to be in hospital when to have the medication? Because that's actually something that people are under the impression that majority of people are going to turn up in hospital to have their medications.
Yeah, so certainly there's no requirement to be in hospital to use the medication, and in fact most people will be using it in their own home or private residence, whether that be home or residential aged care facility, if that's where.
Excellent. Well, the first question I was going to direct, the next question I'm going to get was to Roger here. So Roger, with respect to somebody, what if somebody, for example, with motor neuron disease doesn't have the capacity to write their request because they've lost power in their hands, they can't even do that, or they can't go through the process of signing things and things like that. I mean, what are these individuals precluded from the process given the amount of documentation that's required?
Provided the person has capacity, and that definition of capacity does include being able to communicate, but it does not specify that it has to be in written or oral or verbal communication. communication can occur through gestures. And with someone with motor neuron disease, they might be able to blink or use their eye movements to indicate yes or no to questions as answers. They might be able to just have some movement in a finger to indicate what their wishes are. So, and the legislation is quite clear about this, that a person can indicate their wishes through gestures or other means. So if a person with motor neuron disease can't sign or can't speak, they can still, as a matter of human rights, have their needs met. If they can't swallow, of course, they won't be able to self-administer, and if they can't lift the cup to their mouth for oral administration, then they're in that small group of people under our legislation who can access practitioner administration. In Victoria, I think it's about 15% of all VAD administrations are by practitioners, and I imagine several of those would be because of motor neuron disease.
Great. Thank you very much, Roger. Jocelyn, can I just, if you can hear us there, I was going to pose the next question to you, although you do appear to be frozen. Can you hear me there, Jocelyn? I think, yes, it sounds like you can.
Yes, I can. Thank you.
Thank you. Look, this is the, look, you obviously work in an aged care facility, but I think this will be relevant to healthcare, healthcare facilities as well. I mean, what sort of considerations do health services need to have in place in the event a patient brings in and consumes a voluntary assisted dying substance, not having disclosed their intention to do so? Essentially, they've brought it into your aged care facility. They haven't actually indicated that they had it and they've taken that medication. I mean, what sort of considerations have you had to make for that potential scenario, which I suspect is going to be relatively rare, because one would hope that people are going to disclose this the majority of the time and actually going to indicate this. But I mean, has that been a thought in your planning at all?
It was actually a question very early on. So before the legislation was enacted, staff were asking about that. They imagine that people had their little hidden box and, they'd taken, what would they do? We haven't had any situations where that's happened. The residents that have gone down the VAD pathway have usually had family or others with them. But if there was the situation where the resident had brought in had the medication delivered, or they brought it in with them and they took it, well, then our staff have been educated that they treat that like any other death, where they escalate it to the most senior practitioner on duty or the residence manager. And in that case, that the first contact would be contacting the GP. We contact the Peter Mac, the navigating service, to see who were the contact people in that case. But in essence, the person has now passed away. And as long as the staff are aware of that escalation process and what to do in that process, and so that then the GP or others are involved, then it really isn't treated vastly different. But we did take that into consideration, and in our procedures was actually, we wrote it around the escalation process in the event that such a situation happened.
Thanks, Joseph. Can I say that's an extremely reassuring answer, because I've got to say that's almost been one of the biggest concerns for health services and also aged care facilities. I mean, understanding that, I think it'd be a very rare situation. But can I just say, from our perspective, the implementation task force, the advice we've had is very clear that the legislation does not compel a person to declare that they have the medication in their possession or when they're going to take it. Having said that, that doesn't preclude organisations from having policies with the idea of asking patients to bring that in, and to ideally have policies that they declare it if possible, and hopefully people actually working together rather than doing this in a sort of secret squirrel sort of way, because it would be a much better process if that's the case. But I think one has to understand that there's no legislative requirement for a person to actually declare it. But the flip side is that one would hope that people work together in this and understand everybody's needs. It gets on to the other thing. It's really important that, particularly in hospitals, but also aged care facilities, there are clear instructions about resuscitation, so somebody doesn't unnecessarily start resuscitation should they find that individual passed away. So I'll move on to another question. Roger, I'm going to pass another question to you. So can an assessment occur via telehealth?
Thanks, Chris. Well, I mean, more and more doctor consultations are being done by telehealth, and particularly in the COVID post-pandemic era, there's still a lot of medicine that's being done that way. And for our population of patients with terminal illness who are often very sick, find it difficult to get out and about, being able to do some of the assessment at least via telehealth, it would be very, very helpful to them. And especially for people in rural and remote areas who may not have easy and good access to doctors who can do the assessments. So if they can do it via telehealth, that would improve their access enormously. There's nothing in the South Australian legislation that prevents these assessments being done by telehealth. The doctor, of course, has to be assured that the person meets all the eligibility criteria. But if that can be done by telehealth, the South Australian legislation permits it. However, there is a Commonwealth Act that I think probably was set up to prevent Philip Nitschke and some of his online work, activism. The Commonwealth Act prevents counselling about suicide over a carriage service. I think that's the word that's used in that Commonwealth legislation. So anything to do with the actual administration of a VAD substance, I think that it's prudent not to do that by telehealth because of that Commonwealth law. So that the pharmacists, and Lauren might have a comment on this, Chris, they will have to do a lot of their work face to face and won't be able to carry it out through telehealth.
Thanks, Roger, which goes on to a very nice question, which I can then segue into, which is for Adam. Particularly given the Criminal Consolidation Act in terms of the access via carriage service, what considerations have been given to equity and accessibility if the person lives in a rural area and there's limited medical practitioners or pharmacy access and they live a long way away from where Lauren's working?
Yeah, thank you, Chris. And it is a good segue because those Commonwealth laws are a challenge for us. And I would just add to Roger's answer that all states and territories are currently working together at a national level to look at how that can be changed, given that this has passed through all states now. Regional representation was important from the beginning. So we made sure that we had good regional representation on the task force. We also set up an officer level meeting every second Monday in the afternoon with all local health networks. And so that's had really great representation from the 6 regional local health networks to continue to make sure we are looking at the specific concerns and the specific issues for regional South Australia. There is a regional VAD liaison role, which I discussed before, but also to keep in mind that the pharmacy service and the Care Navigator service are statewide services. And so we did the modelling, as I said, and part of that modelling was also looking at what proportion did we expect of patients that would be accessing the VAD pathway from regional South Australia. And that helped us to inform the size of the resources and the support services we needed to put in place. Now, importantly, the Care Navigator service have a regional support scheme. This is modelled on Victoria and WA. So it uses a very similar scheme to how they've developed it. And so while we're working through the finer details at the moment with the Care Navigator service as they get stood up, really the experience from WA was this is some flexible funding which allows the process to be facilitated when you have someone who's in a regional or remote area. So for example, we might get a coordinating medical practitioner or a consulting medical practitioner out to that region to go out there to meet with the patient. We might pay for an interpreter to go out to all of the consultations to assist the patient. Alternatively, depending on the patient's physical status, they might be able to travel to a local regional centre or to Metropolitan Adelaide. So that's very much how we're looking at modelling it based on the experience of WA and Victoria. But what we know is that for this complex pathway, that is an important facilitator for regional people.
Great. Thanks so much, Adam. And certainly regional rural have been very foremost in the mind in the planning of the implementation task force. Sam, can I direct the next question at you? And look, the question was actually, how did you navigate conversations with family and friends? But I'm actually more interested as much as anything, how your mother also navigated the same conversations with family and friends, because I think that's probably just as important. So could I pose that question to you, please?
Yeah, it's I tell you, at times it is tricky, and even now it's tricky. I have some very interesting conversations with people who are very adamant that she had done the wrong thing, but their belief is their belief, and I just nod and agree and walk away. But no, mum was very strong, and once she told people, they knew, okay, that's Linda's decision, and there was no questioning it. I guess we had behind us, we had visually held someone as they suffered through a terrible drowning in their own fluids, and that wasn't okay to watch a human have to suffer through that. And we were told how mum would probably die, that the cancer would penetrate her esophagus and she would basically drown in her own blood, or it'd take out her heart. So they weren't options for mum. So she very clearly expressed to people, no, this is my choice. This is what I'm going to do.
So thank you very much. And I think that certainty, and that you, again, getting back to the fact you were just supporting her with what she wanted, was the thing that held you true to the whole event, and probably is a great solace, right? Even now, I suspect, just in the way you speak. Look, that goes on very well to the next question, because I must say, even amongst our speakers, but even even in this room, there's been a fair bit of emotion in responding to the speakers today. And look, obviously, it's a very confronting topic, especially for medical and health staff, where you're really focusing on the patient. But how would you see the supports in place for staff who are involved in this process, and what will this look like? Because that will be while you'll be in charge of the review board.
Excellent. No, it's a good question, and I suppose as a psychiatrist, for me, it's an important one. What we're hoping is that we'll be able to help develop a community of practice for practitioners who have chosen to be, VAD practitioners. Also providing ongoing, training and support, probably through ongoing contact and communication with, the VAD team, but also from a board level, I'm in contact with the interstate presiding members, and we're continuing to look at what's supportive for their members, including elements of peer support, being able to find senior members support more junior members who've decided to be VAD practitioners. And then within local health networks, being able to communicate within, their teams around debriefing and support for their teams. And as a part of our meeting, every time that we do as a board, we'll be looking at the processes and how it's working for the care navigators and for the LHN VAD liaison nurses, and gathering feedback about whether more support's needed, whether we need to implement something different.
Right. Thank you. And I think that's important to understand. This is a very emotional thing for everybody concerned. Claire, could I flip a question to you, please, which is, how does your organisation support your role? And is there dedicated resourcing for your role, and for, going out to patients' houses, for example, homes, for example. How does it look in terms of your support?
So I've been extremely lucky from the beginning that the executive of my organisation, first of all, just decided that they needed a clinical leadership role in the first place. So I got the job by an EOI. There was a sort of competitive selection process, and I got that. And from the very beginning, they said to me, look, we as an organisation want to support this. We honour it as a choice that patients will be legally entitled to, and we want it to do it right. So they actually use the words carte blanche. You can go off and just create the service that you think is what patients should be able to access. And all the way through, they've listened to me and responded to me and supported me. And they've actually, my role was only initially for the first 6 months up until the day of enactment, but they've actually continued to renew my contract at various different sort of points between a 0.2 and a 0.8 FTE, depending on where we were in the kind of process. Now that we're moving into that sort of more business as usual model, my role is still funded at a 0.2 FTE. And we are getting to the pointy end of it, which is that there really isn't any ongoing funding at all. All the funding for the enactment and for the first year or 18 months of operations has been from our HSP. So each of the health service providers has had to find their own sort of pot of money. There's been nothing for the practitioners forthcoming from the Department of Health. And it is an increasingly big issue, and one that I'm hoping will be approached at a more sort of national level now that all states have come on board, because the reality is that a lot of us are actually doing this work unpaid and sort of pro bono, if you like, because the need is there. And when you know that there are patients who are suffering and patients who want to get this as an end of life choice, you're not going to do it just because there's no money to do it. But I've actually been in a meeting this morning about trying to get some more funding and putting forward a Treasury bid to actually acknowledge the amount of work, the fact that there is about 3 times as many patients looking to access it as the modelling was funded for in the first place. And things like, the Care Navigator service and the pharmacy service are well funded and have had their funding increased because they've shown that there is the requirement for that. But individual practitioners, it's a bit of a struggle because people take very different amounts of time to move through different parts of the voluntary assisted dying journey. So it's quite hard to put forward a budget for, and ultimately we are doing a lot of work off our own back. So watch this space. I think it's an ongoing process.
I thought the carte blanche sounded very good, actually. A whole number of areas in health that would have been excellent. So look, I'm going to break a question up. We're getting into some nitty gritty questions in terms of ethical matters and legal matters as well. And this question will be from Melanie. And this is with regards to, and the question is, I appreciate the terminology of certain mental health conditions, but it's not as black and white. And the sort of condition we might talk is anorexia nervosa. Is there any discussion or possibility for a person to be eligible for voluntary dying for a person with with an illness such as voluntary dying, for which they may be dying in the next 6 months or so?
It's a very good question. It's a very complicated question. I think that anorexia nervosa is probably one of our more challenging scenarios that we're looking at, because that is often a significantly severe mental illness, often comorbid with a physical illness. It can have improvement being admitted to a ward. For some people, it doesn't. And I think, we're having ongoing discussions really, both sort of ethically and clinically, about that particular patient population. I think that it's important for us to also know that general mental illness is in a significant proportion of your average person walking down the street. So there'll be people that have depression and terminal colon cancer and, anxiety disorder and motor neurone disease. And having a mental illness like that doesn't preclude you from moving through the VAD pathway. That if you meet the other criteria, you can move through the VAD pathway. And probably what it would be a case-by-case basis for people with some of those really severe physical and mental illness combined disorders. And it's something that we continue. We've just spoken about in our last 2 review board meetings about that matter in particular, and talking to other areas. That's also been something they're continuing to deal with. And so I suppose the answer at the moment is if somebody applied for that, then that would be something we would really be considering a review board ethical kind of level about where someone fits in that kind of spectrum.
Is it right that the legislation actually indicates mental health conditions particularly and not specifically cannot be used as reasons? Is that right? Specifically?
Yeah.
But
So
the question is where the line is.
It is. And I think that we've, so if you have very challenging to treat schizophrenia, you otherwise don't meet any of the criteria, and that particular illness is not treatable. At the moment, you do not fit the VID criteria to go in the pathway. The challenge with anorexia is that the physical comorbidities that you could have, such as significant heart failure, significant cognitive impairment, literal sort of almost palliative status, that's where you sit with that challenging line with that illness in particular.
Do you mind if I take on the second part of the question? Second part of the question was, does the presence of a mental condition with another organic terminal illness that does fit the criteria complicate a person's access to VAD? And it was interesting because we've had one question to say, did Chris Moy say that person with dementia, therefore early dementia, can therefore access voluntary assisted dying? What I was trying to explain that was the question about decision-making capacity. So essentially an individual with a coexisting condition which might affect decision-making capacity. Well, first up, they have to fulfill all the other criteria first, 6 months, 12 months, the condition is causing distress that they can't cope with. But then the next question is this issue about whether they have decision-making capacity. And then you have to decide, does early dementia or does a depression, in that, do they have decision-making capacity, which is actually going to be genuinely their decision? And one of the interesting things that comes up with this is that first up, you have to go through the process. So decision-making capacity, I'll go through it again, is presumed. It only applies to the decision that has to be made. You have to consider a fluctuation of decisions. And it's 4 bits. Can you understand what you're told? Can you actually keep it in your head long enough to weigh up risks and benefits? Can you weigh up the risks and benefits? And can you express your wishes? Now, the thing about it is that it's very interesting because when people look at this, they're looking at the diagnosis. The diagnosis, to some degree, with regards to determining decision-making capacity, is kind of irrelevant. It's whether they can make the decision. And I think there is, unfortunately, quite a view out there that, decision-making capacity is purely based on a diagnosis. Somebody has dementia, they haven't got decision-making capacity. Somebody has depression, they don't have decision-making capacity. Somebody's got blood alcohol of, 0.1, they haven't got decision-making capacity. Somebody's got a mini mental of, 25, they haven't got decision. It's got nothing to do with that. It's whether they can do those 4 things from a position of presumption, and whether they've got mild dementia, as long as they fit the other criteria, as long as they've got those other bits, then they may still be able to access voluntary assisted dying. What I'd like, a couple of minutes? A couple of minutes. Look, I'll move on to one final question, which was very relevant to the one that I gave Claire. But I mean, look, one of the things is obviously there's the reality of the amount of time that's required to provide voluntary dying. I've got to say this applies in a whole number of other areas as well, such as palliative care. So we have to actually bring that into the bigger world here. But I mean, there will have to be a lot of, let's just say, care of the patient, altruism, sacrifice, I think, to some degree, because there were a significant time, some of which may not be billable, for example, in the private, by Medicare, for example. Roger, I'm going to pose the question then. I mean, in the world reality, is it reasonable that doctors or health practitioners charge like they would normally privately for people to access, keeping in mind, obviously, individuals' ability to pay and their willingness to, work with their patients, just like in other area, and give informed consent? Is that reasonable? I mean, in the provision of voluntary assisted dying?
That's a really interesting question, Chris. And I think individual practitioners will approach it in their own way, but we certainly know that for all sorts of medical procedures and consultations, there are gap fees, and depending on the choice of the doctor and their business model and everything else. I think in palliative care, we haven't tended to charge any gap fees, even for the doctors working in the private sector of palliative care. And Claire might be able to answer whether the doctors providing VAD services in Western Australia, whether they charge any gap fees. But I suspect the tendency has been not to, but I think with the lack of government remuneration for the services, I think doctors might need to consider charging gap fees.
Yeah, I'm
Claire,
happy
are you
step
happy
in
to
there.
respond to this?
Yes. So certainly in my practice, I'm funded by my health organisation to provide services. As I said, initially it was a clinical lead, but they're very happy for me to act as a voluntary assisted dying practitioner under that sort of fee structure as well. So I personally don't charge. And at its most sort of fundamental, the whole provision of voluntary assisted dying services up to and including the medications are all free. So a patient doesn't have to pay for anything in relation to access. That being said, as we've all identified, there are people who work solely in private practice, and there are also colleagues of mine who provide a much more community-based service, and they do charge for those services. It's very difficult to find the right fee structure, the right charges. There's no Medicare item numbers, which is another enormous issue that now hopefully will be discussed at a national level. But the reality is that this work takes time, it takes energy, and it is something that remuneration should be an accepted part of practicing. I'm just lucky that I can do my work under the umbrella of what I'm already paid for, but I still do over and above that as well.
Thank you, Claire. Look, I wanted to bring that up because I wanted to bring up the reality of where it is in terms of the level of support for doctors or other health practitioners who may want to get involved, who are really going to go above and beyond. And they may be supported by the way the health system is funded. And I think the main principle is that informed consent is there. There's informed consent about the costs up front so that individuals are actually given the information. There are general principles about that. So people are aware about it. It's upfront. It's a negotiation. And ultimately, that doesn't become a barrier to, and in fact, possibly becomes a facilitator to, in fact, people accessing care. Look, I think we've run out of time. So I might then, first up, thank you all the panelists who have been absolutely wonderful, fantastic answers, perfect actually answers at various stages to the questions that we posed. But thank you very much. And look, I'll say thank you. And I think I'll pass over to Pam, who's going to do the next
I'd like to
introduction.
take this opportunity actually to thank, first of all, Dr. Jocelyn Small for being with us, Dr. Claire Fellingham and Sam Cox. I just can't thank you all enough for actually giving up most of your day today to be part of the SA Voluntary Assisted Dying Conference. We really appreciate your time, and we thank you with greatest respect, and thank you for sharing your stories and your experience as a voluntary assisted dying in your area. What I'd like to do now is we have one last speaker, actually, before we then go into the wrap-up session. We've actually got Dr. Melanie Turner, who you've met during the panel discussion. Dr. Melanie Turner is going to be with us today to talk to us about the doing some wrap-up, but also talk to us about the review board. She is being appointed as the presiding member of the Voluntary Assisted Dying Review Board, and I'd like to welcome her to come forward now before we wrap up.
All right, fantastic. So thank you all of you for coming and joining us. It's amazing to think there's hundreds of you out there while I stare at a not quite empty room. Really just to sort of recap, so my name's Mel Turner. I'm the Voluntary Assisted Dying Review Board presiding member, and I'm a psychiatrist here in SA. Today we've heard from a lot of speakers. In particular, we've looked at really what VAD means for our community, and I'm so grateful that we were able to hear about clinicians and hear about people that had gone through the experience of VAD and their family, and really thank them for their time. But also the practicalities of the timeline of VAD, of what a consulting and coordinating practitioner is, meeting different members of our team, the pharmacy team and clinical navigators, and people that you will meet if you become a VAD providing practitioner. We also have heard about our progress to date to implement voluntary assisted dying as of 31st of January next year. You've met a lot of people who've put in a lot of time, and we are still working very hard to get everything ready so we can provide a safe and transparent process. We've also looked at how the process occurs in practice, and I'm thanking our clinicians, particularly Roger, who's spoken to us today, and our step-by-step video, which showed you our case of Alan. We've also heard about the supports and safeguards that are in place. You've probably heard we have sort of over 70 safeguards sitting within our legislation, and some of ours, including having your contact person, having witnesses, having 2 practitioners, and our timeline all support that. And we've heard about our lived experiences. And I really want to thank the people who've spoken before me today and the wonderful job they've done, hopefully sharing all their information with you. So really, part of my job is to ensure that we provide a safe VAD, that as a review board, we have an overarching view of what's occurring, and that we have safeguards and principles embedded that represent what our community and our clinicians want for voluntary assisted dying. So it's really our overarching view that we're looking to provide. And our goal is that we focus on our patients, we focus on those wanting to access VAD, we focus on our clinicians and our guiding principles that we have in our Act. So the nuts and bolts of the Voluntary Assisted Dying Review Board, basically it's part of the legislation that there's an oversight kind of pathway. When you put all of the pieces together for the legislation, we needed to have an independent body, and that's what the Voluntary Assisted Review Board is. We were appointed by the Minister for Health and Wellbeing in September. There's a similar body, particularly that have been running in Western Australia and Victoria. There's a new one in Queensland and a similar one within Tasmania, because basically each state that brings in the legislation requires an oversight mechanism. So who are we? I'm really delighted that I have a wonderful review board. We have met a number of times, and we really represent quite a variety of skills, but also different parts of the community. So on the list, there's me as a presiding member. I'm a psychiatrist, and I've got different experience within the medical board as well as the College of Psychiatry board, and I continue to work in clinical practice. Helen Walker is our deputy presiding member, and she's a specialist palliative care nurse. She has postgraduate qualifications in palliative care. She's an experienced manager in a range of settings, both public and private, and she's almost finished her time working as the nurse unit manager of Laurel Hospice at Flinders Medical Centre. She's been vice chair and almost finished her term with that with the Palliative Care Australia Board, and sits on the advisory committee for the QUT End of Life Law for Clinicians Education program. And I'm really proud that she's my deputy presiding member as we move forward. We have the Honourable John Dawkins. He's a member of was a member of the SA Legislative Council, representing the South Australian division of the Liberal Party from 1997 till 2020. He was an independent MLC and as president until March 2022. In 2018, Mr Dawkins was announced as the Premier's advocate for suicide prevention and was a member of the Premier's Council on Suicide Prevention and chair of that council until September 2020. And John was very significantly involved in the VAD legislation. Roger Hunt, who you've met, is a very experienced clinician with more than 38 years of working in palliative care. And he was a founding member of the Door House Hospice and director of the Western Adelaide Palliative Care Service. He's been awarded Doctorate of Medicine by published work and has lots of involvement in the introduction of voluntary assisted dying laws interstate and in South Australia, and has also been a member of our implementation task force. Rainer Joseps has extensive board experience as a member and chair, and he comes as a community representative with significant volunteer experience as a lifeline crisis counsellor and as a support person for someone with an advanced neurodegenerative disorder. He provides wellbeing and pastoral support for large corporate, government and not-for-profit organisations and has an accomplished executive career. Greg May has extensive legal career with 30 years in various roles in SA, including as chairman of the chief operating partner and general counsel at Minter Ellison, and is retired after more than 8 years in the role of Legal Profession Conduct Commissioner. Michelle Smith is a certified healthcare executive and professional company director with 36 years experience in health and human services industry, and was the inaugural governing board chair of the AIR Far North Local Health Network in SA. She has also a registered nurse, a fellow of Australasian College of Health Service Management, and a member of the AICD. And Helen Stone is a registered pharmacist. Ms. Stone's the current state and territory manager for the Pharmaceutical Society of Australia, has received grants, published articles and led projects across Australia, and is currently just coming back from her Churchill Fellowship. So I'm really pleased that these are the people leading our VAD review board. My screen's stuck. There we go, magic. So what's our purpose? Well, lots of people think boards and committees don't do very much, but I promise you we're very, very busy people. So our job is to oversee safety and quality. Do you want me to stop? Yep, this is just closed down. I could tell when it froze, it did the blinky thing. That's all right. Apparently I'm still live, but I've lost my screen. So I'm just going to read off my sheet, everybody. Hope that's all right. So my job really is to make sure that our review board oversees the quality and standards of voluntary assisted dying, and that we make sure we keep up with the Act, which I think I've read 50 times. And that's my job, is to know that really well, make sure that we meet all of those requirements for you. You'll probably meet me when I come and do stakeholder meetings. I come and have some feedback sessions. Hopefully we get involved in some training. And we continuously make sure that there's quality and safety in what's being provided, that we are providing the right training for you, that we're providing an avenue for feedback, and that we're collecting the data that then puts together what this really means in our community to see if we need to change the shape or of what we're doing. The next part I talk about is how we work. Really, we meet at a regular monthly interval. We really strive to make sure that we always follow what's in the Act, and our focus is on transparency, responsibility and accountability. And I think my screen is doing something different. Excellent. So what we really do is we're going to actually every month be able to review the data of who has requested voluntary assisted dying, the number of people that have registered for the training, and also the feedback that we've received from consulting practitioners, care navigators, pharmacists, and anyone else that contacts our secretariat or the Voluntary Assisted Review Board. We plan on receiving local updates from all the LHNs, the Clinical Navigator Service and Pharmacy Service, and you'll be able to see every quarter a report of a summary of all of that, so that you're able to actually know what voluntary assisted dying in SA is looking like at the time. And then every year we have a duty to also do some analysis on that data, provide some information about how we might use that in research, as well as do a yearly report, which is a requirement for our role. Okay. So our upcoming priorities, really our goal is to make sure that we continue to establish really good solid processes. We have really good feedback and complaints procedures, so that you know how you can get in touch with us, know how you can provide us with advice onto what you think may be done better or differently. That we build our key relationships, and that we support our interactions in between different LHNs and with ourselves, and hopefully professional bodies that would like to hear from us and work with us. Really, our plan is that we continue our focus on the patient, on the clinician, on a really safe, high quality process that is equitable for everybody. And that's going to continue to be our goal. And we'll continue to work hard to make that happen for all of us here in SA. Thank you very much.
Thank you so much. But I'd like to now ask Helen Chalmers, the Executive Director of Health Service Programs, and Helen's actually the Executive Lead for the Voluntary Assisted Dying program here in SA. I'd like her to come forward and officially wrap up, and then we'll close. Thanks, Helen.
Thank you very much, Pam, indeed. And good afternoon, everyone. And I think we may have a few good mornings or possibly good evenings as well. We have international attendance today, which is incredibly exciting. I am just going to, as you said, make a few thank yous and talk a little bit about where to from here as well. This is an incredibly important change in our South Australian community. And you can hear today and see by the number of registrations, we had nearly 1,000 registrations, just how much interest there is in this topic as well. And today we've had the real privilege of an incredible amount of facts, of insights, knowledge, experiences, and some incredibly personal journeys that people have taken in parts of Australia where this is already available to them. And I've been incredibly grateful for the generosity of speakers in sharing their knowledge and their skill and personal and professional engagement. The event today has been orientated towards our clinicians, but we know we've had a lot of interested people from all parts of our community today. And I really do thank you all for your attendance and for your interest. I'd like to particularly single out our speakers today. Pam Zervas, who's been our facilitator today, and her team from Z. You've done a remarkable job supporting this, and you've been integrally engaged in our project for a while now, so thank you. Our Minister, the Honourable Chris Pecton, and our Chief Executive, Robin Lawrence, who both opened and gave context for us this morning, as well as some of the journey that got us here. Similarly, Dr. Roger Hunt, Dr. Chris Moy. Adam Monkhouse, Lauren Curtis, Emily Pumper and Joyce from our VAD team all did a tremendous job this morning talking about some of the services and the way we'll operationalise this next year. Dr. Melanie Roth and Dr. Jocelyn Small, Dr. Claire Fellingham for sharing their experiences and their knowledge with us. I don't think any single person here would fail to want to single out Sam Cox, whose powerful story resonated with so many, and your bravery in sharing what was a very beautiful story in many ways, and yet so hard, is so appreciated by so many. I can't tell you how many personal thanks we've had just from people who don't know you. And closing, of course, with Dr. Mel Turner as our chair of the VAD board. And those of you who then joined our panel, who kept me entertained despite the Zoom failure, which fortunately was just for a minute. The very powerful video that's been produced will become available, and I think will become a really helpful educational tool for those of us wanting to know what the process may look like. And that was its first public airing today, although in the 5-minute segments that you saw. I'd like to recognise a few people for this event today. We have a remarkable team working in voluntary assisted dying and end of life generally, and I can't name them all, but I would like to single out Kate Swetnam for her work to bring this important day together. She's done a remarkable job, supported by many. And also, I'd just like to note Drs. Chris Moy and Mel Turner, who lead our task force and our board respectively, as well as the members on those groups who participate so strongly in this work for us. So where to from here? We've touched on a little bit of this, and I'll just reiterate a couple of points. This conference is recorded, so it will be available to you, and we will issue FAQs, as they're often known, frequently asked questions, from the questions that were provided to us today. Thank you for everyone who came in on the chat line for that. There is also a contact, and I'm just going to have to look that up. Just let me check on that. Oh, look, my lovely person hands it to me. health.voluntary-assisted-dying@sa.gov.au, where you can send inquiries and queries to us as well, so that we can keep an eye on those and keep responding to those. We'll continue to issue newsletters, and I envisage the frequency of those getting a little more intense over the next couple of months. And we'll take the opportunity not just to have them on a website, but shared via newsletter as well. So VAD will go live in, I think we're 77 days from now, from the 31st of January. We are, as we said earlier this morning, we're working in real time to be ready for this, and people are working on all aspects. Critically, as the Minister announced this morning, registration for coordinating and consulting medical practitioners will be available through the VAD clinical portal from the 28th of November for those who have registered or registered between now and then. And that will allow anyone who's registered to access the link to the mandatory training. After that date, we'll continue to be rolling out all the essential products and services between then and the 31st of January as we get ready to take this program live. So I'll pass to Pam, but let me just close again by thanking you for your interest, for your support for this program, and our speakers and everybody else who worked to bring this to you today.
Thank you, Helen. I'm here to now officially close the session. And so I wanted to thank everybody for joining us for the whole day. And as Helen mentioned, you will see an online recording over the coming weeks being made available, and also FAQs will continue. So I'd like to officially close the SA Voluntary Assisted Dying Implementation Conference, and thank you for your attendance.